Hello everyone. Today we'll be talking about Stemi ECGs, its identification, and what are its mimics. Myself, Dr. Akif Beg. I am a consultant intervention cardiologist at Aster Ramesh Hospitals, Guntur. So herely we describe a case of 56-year-old male who came with complaint of chest pain since last 6 hours. He's a known case of diabetic and hypertensive. As you can see here in this ECG, there is a clear ST segment elevation. So basically to remember the ST elevation, always remember that if you take the normal ECG, so this is what is called as the J point. To call it as ST segment elevation, there should be a significant J point elevation. So if the J point elevation, the diagnostic criteria says that in if you are taking lead V2 and V3, the elevation should be more than 2.5 millimeters if patient is a male with an age of less than 40 years. That means that less than 40-year male should have elevation of more than 2.5 millimeters in V2 and V3. Whereas if the age is of patient is more than 40 years and male is there, then it should be more than 2 millimeters. So similarly, for females, the criteria says that it is more than 1.5 millimeters irrespective of the age. Other than V2 and V3, if there should be ST segment elevation of at least of 1 millimeter in any other leads in more than or equal to two contiguous leads. Contiguous leads. So here you can see here whenever there should be J point elevation, which means that J point should be elevated here. So this is a J point which is shifted from the baseline from here to here. You can see in this ECG, this is the baseline horizontal point. There is elevation of around each small square is 1 millimeters. So around 5 millimeters, so more than 5 millimeters. That is in the V1 to V4. So this is anterior wall MI. Also, some amount of elevation is there in V5, so you can interpret it as lateral wall as well. So anterior wall MI, for just a brief review, I can see that tell you in brief that anterior wall MI elevations are usually seen in V1 to V4. Lateral wall MI, the elevations is seen in lead V5 and V6 because in chest leads, whenever we place the leads, V5, V6 are kept near the axilla, so that is the lateral part of the body. Also, lead A1, AVL, lead 1 and AVL. L means nothing but left arm. Left arm is again near to the lateral part of the body, near to the axilla. So that's why AVL also comes under lateral wall MI. And coming to inferior wall MI is usually seen in lead 2, 3, and AVF. So this is a case of acute anterior wall MI, anterolateral wall MI, because elevation is also there in one and lead AVL, which is subtle elevation that is more than 1 mm. Important thing to identify is that in any patients of STEMI, there should be a reciprocal ST segment depression. As you can see here, these are the reciprocal changes in the lead 3. So this only in presence of ST segment depression, that is reciprocal changes only, you can label the patient as STEMI. Okay, so this is case of hyperacute anteroseptal STEMI, ST elevations in V2 to V4. Okay. So let's go to the next ECG. So here you can see here another similar ECG is you can see there is ST segment elevation in the lead 1 and lead AVL. So lead 1 and AVL comes under lateral wall. So normally what they say is 1 and AVL comes under high lateral wall MI and V5 and V6 comes under low lateral wall MI. So here in lateral wall, there is hardly any elevation. You can maximum see elevations in the lead 1 and lead AVL with the reciprocal changes. You can see here, this is a horizontal point. There is ST segment depressions in the reciprocal changes, that is lead 3 AVF. So this changes confirms that this is a high lateral wall MI. So you can see this high lateral wall MI. So another patient ECG, this is a very interesting ECG, often misdiagnosed or missed by a lot of physicians. So you can see here patient coming with a chest pain, classical chest pain, and you can see here this is a classical what is called as ST segment depression. So this is the horizontal point. You can see here ST segment depression is there here. So as I discussed that, because normally what I said that suppose there is ischemia in any part of the body, in the opposite changes, there will be reciprocal changes. That means the reverse changes will be there. So suppose there is ischemia in the anterior wall, reciprocal changes will be seen in the posterior wall. So what do you mean by reciprocal change is that suppose in anterior wall there is ST segment elevation. As you can see here, this is the ST segment elevation. You can see this is ST segment elevation. Posterior wall, there will be opposite changes. That means that what do you mean by opposite changes is that you will see a ST segment depression here. So in place of elevation, you'll see a depression. So this depression changes is called as posterior wall. So supposing that patient has a posterior wall MI, patient develops STEMI in the posterior wall. So what will happen is that this ECG changes will be seen in the posterior wall and the reciprocal changes will come in the anterior wall. So you can see here there is ST segment depression in the lead V2 and V3. And since in the routine ECG we do not take posterior wall, posterior leads, you only will see the reciprocal changes in the anterior leads, that is V2 to V3. There will be ST segment depression with the T wave up T wave. So same patient, when you take a reverse, that is posterior leads, that is called as lead V7, V8, and V9, which is kept in the posterior side in the fifth intercostal space. V7 it around the posterior axillary line V8 at the infrascapular, and V9 is paralumbar, that is paraspinal. So just lateral to the spine, you'll keep it. And this lead, when you take the lateral leads, you can see here V7, V8, V9, there is a ST segment elevation. So this changes in the V2 and V3 were reciprocal changes. So always keep in mind when you see any patient of chest pain, classical chest pain and angina, ECG, if it is not coming to be STEMI, you see the ECG in this pattern. If there is posterior wall changes is there, then you label them as posterior wall MI. To take a posterior leads, that is a clue here. Similarly, another patient coming with chest pain, you can see there is elevation in the lead 2, lead 3, and lead AVF. So there is lead 2, 3 AVF comes under what is called as inferior wall MI. So based on ECG, we can also say which vessel is involved, because normal Anthoven's triangle, if you remember it here, so this is the lead 1, okay, and this is the lead 2, this is the lead 3, and here it comes the lead AVR. You can take it AVL and what is called as AVF. So important thing to remember is that in this patient, lead 3. So suppose heart generally comes here. I'll show you that. So heart usually comes here. So this is the heart, which is normally you can see here. It goes like this. So that means that the right ventricle part usually comes at around the lead 3, and the lead 2 at around lead 2 generally it is only the basis of the right ventricle or near the left axis is there. So suppose a patient has a right coronary artery occlusion. Right coronary artery usually supplies the right ventricle. So if there is RC occlusion is there, then the elevation in the lead 3 will be more than the lead 2. Supposing patient have a inferior lobectomy due to left circumflex artery occlusion. Left circumflex artery is more near the septum and towards this interventricular septum, and also supplies the inferior wall, but it is more in the direction of the lead 2. That's why the lead 2 elevation will be more here when compared to the lead 3. In this patient, you can see here lead 3 elevation is higher when compared to lead 2. So you can suggest that this patient will have a right coronary artery occlusion. So also important thing to note that in any patients of inferior wall MI, right ventricular MI is also often associated. What is the clue in ECG for right ventricular MI is that elevation in the V1 more than the elevation in the V2. So you can see the subtle elevation here in the V2 as well, but V1 elevation is more than V2. V1 is usually kept because when you remember the chest leads, V1 is actually kept at, suppose this is the spine, V1 is kept it around the right fourth intercostal space. That is on the right side it is kept. V2 is kept on the same fourth intercostal space but on the left side. Since V1 is on the right side, it will detect more of the right ventricle, that is right side of the heart. So that's why right ventricular ischemia will cause elevation in this lead. So you can see here V1 has an elevation more than that of V2. So elevation in the lead V1 and V2 suggests RC occlusion with associated RV infarction. So same here, you can see here elevation and infarction. You can see ST elevation is seen in V1 and also ST elevation in lead 3 is more than lead 2. This is all favor of right ventricular MI. So sometimes, often to confirm, we take what you do is we take V4R, we keep it at the right side. So similarly, so where we kept is V4 lead normally is kept in the fifth intercostal space in the mid clavicular line. That is mid clavicular line. Similarly, that is in the left fifth intercostal space. Now, if you want to do check for right ventricular MI, what we have to do is we have to take this lead V4R and we have to keep it around right fifth intercostal space in the mid clavicular line. Then you will get a classical ST elevations in the V4R lead. So that confirms that it is ischemia. So now the main STEMI we have discussed. Let's go to the other causes which appears as STEMI but are not actual STEMI or can be a mimic of STEMI. So you can see here there is an ECG which you can see here. You can see in the lateral leads there is what is called as M pattern in the lateral leads, broad QRS complexes, and also with concordant or discordant changes are seen. So that means whenever there is, this is a classical case of left bundle branch block. So you can see left bundle branch block here, and whenever there is left bundle branch block, what happens is both depolarization and the repolarization gets affected. So depolarization is determined by the broad QRS, as you can see our M pattern here. But also along with that, whenever depolarization is affected, repolarization of the ventricle will also get affected due to the bundle branch block. And that's why you said you see a discordant changes in the ST segment and T inversions. Similarly, if you can see QRS is dominant in that is S wave is dominant here. Now you can see that this ST segment or what is called as the T wave is more of positive in the this lead. So there will be discordant changes you can see here. So to label LBBB as sometimes patient of STEMI if have they can also actually present with left bundle branch block, but it can also be a normal phenomena. But if a patient is symptomatic, you should always suspect that it can be ischemia. To label them as an ST elevation MI, the patient should fit the Garbosa criteria as defined as, suppose usually what I said that if a RQRS is dominant here, there will be discordant changes. That means ST and T will be in opposite direction. Now, if in the same lead, if the patient is suppose having a ST segment elevation, so in this discordant changes has now turned into ST elevation here, then it is suggestive of ischemic LBBB. Similarly, if you want to see ST segment depression in other leads, uh, so wherever there is negative QRS, as you can see here, this is negative QRS here. In that lead, you have to see that there is a ST segment depression. So normally we will expect that ST and T will be high elevated here, but it is ST segment depression if it is there. That also comes under Garbosa criteria, which is given a 3 points. Similarly, suppose patient is having discordant STT changes, but if this ST segment is elevated, if it should be elevated more than 5 millimeters, then it is called as what is called as a criteria for Garbosa criteria. It is given as 2 points. Now, in the modified Garbosa criteria, what we have seen that they have changed this 5 and they have said that if this elevation is more than 25% of height, that means that suppose this height is around 6 millimeters, this should be at least more than, if it is more than 1.5 millimeter, that is more than 25% of this part, then it is labeled as what is called as positive Garbosa criteria. So coming to the next ECG, you can see here, this is the ECG. Patient is complaining of chest pain or may not have a chest pain, classical pain. This type of ECG, often we get committed that this is looks like an ST elevation here. Here also you can suspect that there is minimal ST elevations. But important thing to remember that this is a ECG of what is called as benign early repolarization. So because in repolarization also there will be ST elevations, but the ST elevations are usually you can see here this is concave shape rather than convex, and also there is no reciprocal changes. You can see there is no reciprocal changes in any other leads. That means there should be ST segment depression in any of the leads. That is not there, and also important to see that there is something called as a J marker. There is J point. Okay, you can see a prominent J point which is seen in cases of benign early repolarization. So benign early repolarization, you can see how it is defined as is. You can see here ST segment elevation. There is widespread concave ST segment elevation, especially in the mid to left precordylids. You can see there is concave type of elevation. You can see here again here, this is a concave type of elevation in the anterior lids, which is there. And there will be notching or slurring at the J point. You can see, you have already seen here, there is a notch. So this is a notching at the J point, which is seen here. That is benign early repolarization. So sometimes this characteristics is also similarly seen in what we call it as pericarditis. So how do we differentiate pericarditis with this? Because in pericarditis also there is J point or there is concave shaped of ST elevation. So important thing to remember that they have given something called as ST by T wave ratio. So that means that amount of ST elevation, suppose you see a ST elevation of 1 millimeters, and what is the height of T wave? So suppose here you can see here the ST segment is minimal, that is 1 millimeter, whereas the T wave height of T wave you have to take into consider, which looks almost around 7, almost 7 millimeters. So when you divide this ratio, if this ratio is coming to be less than 0.25, it is benign early repolarization. If it is more than 0.25, then it is called as suggestive of pericarditis. So this is an important criteria how you define that. So that means here you can see 1 by 7 is less than 0.25. So this fits under benign early repolarization. Okay, so let's go to the next ECG. So you can see another ECG, just classically, it also appears like there is some ST elevation here. You can see the J point is elevated, but as we know, this is a classical case of what is called as Brugada type A. So Brugada, what is important here is that you will see is this type of ECG, which is called as coved ST segment elevation of more than 2 minutes. So this is coved ST elevation of it should be more than 2 millimeters minimal has to be there in the anterior lids, that is a lead V2 to V3, V2 to V4 anywhere. If you see this type of pattern, that is called as Brugada syndrome. So you can see there's three types of Brugada. Type 1, when there is a coved ST segment. Here it is, you can see it is called as saddle shape of ST elevation of more than 2 millimeters, which is called as type 2. Type 3 is can be mixture of both of them, but the elevation is usually less than 2 millimeters. So this is also an important ECG which you should remember for exams because it almost resembles like that. Often we get confused and suspect that this is a case of STEMI with T wave inversion. So you have to be very careful in that. So important thing is that to label any patient as Brugada, along with the ECG criteria, patient should also meet a clinical criteria which is given as. So following 6 points are there, out of which at least 1 point should be there to label the patient as Brugada syndrome. That means the patient should have a history of ventricular fibrillation, and patient should have a family history of sudden cardiac death, that is before the age of 45, presence of a cove type of ECG. Suppose you are doing an EP study, that is electrophysiological stimulation, there should be inducibility of VT. Patient should have episode of syncope and occurrence of nocturnal agonal respiration. So all these things features one should be definitely there along with the ECG criteria to label the patient as Brugada syndrome. So coming to the next ECG, so this is also sometimes we get confused here. Often this is described for a patient of CKD. You can confuse that this is an ST segment elevation here, so which is there, but it is not of STEMI. It is basically because of the CKD, that is hyperkalemia changes. There is increase in potassium, which can give a very tall T waves. You can see this is very tall T waves can be seen here, which is classical of scene of hyperkalemia. So hyperkalemia, if it is very severe, so based on potassium levels, the changes appears at around 5.5 to 6.5. You will only see the peak T waves. 6.5 to 7, you will see the flattening of P waves. PR will be prolonged and P wave eventually disappears. And 7 to 9, you can have actually arrhythmias. So this is a classical case of what is called as wide QRS complex. You can see here, this is wide QRS complexes, which you can see here. Also, there is prolonged PR interval. So PR interval distance is increased. So let's go to the another patient who is presenting with chest pain. This is a classical chest pain. Patient often complains like they gets aggravated on lying in supine position and relieves on leaning forward position. And what it is nothing but it is pericarditis. So pericarditis, you can see that is ST segment elevations. You can see here. So this is again I said it is the concave type of ST segment elevations you can see. Important thing is that along with concave type of ST segment elevation, there is PR depression. You can see here this PR depression is there. So you can also see similar changes in the PR depression here. Also in the lead AVR, there will be reverse changes. That is, PR will be elevated. You can see here PR is elevated when compared to the baseline, and there is ST segment depression. So ST segment depression here, which is called as pericarditis. So acute pericarditis versus STEMI, how do you differentiate that? Usually ST elevation is less than 5 millimeters in pericarditis. In STEMI, it is more than 5 mm. ST segment type is usually concave, that is smiling type of ST segment elevation, whereas convex type, that is ST elevation is usually what is called as is dome shape. And there is diffuse ST segment elevations in ST lead, that is usually it involves the diffuse lead does not localize to a single territory, but usually it is in the limited to a single territory in case of STEMI. Reciprocal changes are not very prominent. It is very much pronounced in STEMI. PR segment depression is not seen in STEMI, but it is seen in acute pericarditis. So next, going to the another ECG, you can see here patient coming with chest pain. On when he came to the at home, he has chest pain. Now he is came to your emergency room. When now patient is doesn't have any chest pain. Chest pain has resolved, and when you take this ECG, you find this pattern. So what it is classically called as Valence syndrome. There is Valence type A. So these patients are often very important because this can be a patient can be very much danger because patient usually have a ostium or LAD stenosis. There is left anterior descending artery stenosis is usually there, but it is what is called as because of sudden clear of some thrombus, patient may feel better. There is no symptoms, but always there is high risk of occlusion of this LAD in the ostium or proximal LAD. So any pattern of the CCG you see anywhere, you should always be take immediation immediately for revascularization. Don't go only by the symptoms wise, because if you do not revascularize them properly, patient can land into fatal arrhythmias and mortality. So this is type A. You can see this part of pattern and deep P waves. That is this is called as biphasic T waves. This is called as deeply inverted T waves, which is seen in Valence type B. Next, coming to clinical significant, patient may be asymptomatic. However, there are very high risk of experiencing a significant anterior MI within the next few days. So, because of this severe stenosis of left anterior descending artery, this patient typically need invasive intervention. Okay, next going to another ECG, which is very rare, but a phenomena which is defined as you can see here. There is ST segment elevation in only lead 3. So we often say that suppose there is only single lead elevation, it should never be taken into consideration. So it is always for labeling patient as STEMI, there should be more than or equal to two contiguous leads. In this patient, you can see clearly that it is only there in lead 3, but no elevation in the other leads. Lead 2 and lead 1 are normal. So now, how do you treat this case? Why do you suspect this case? Is important thing to note here that you can see here there is ST segment depression in the lead lateral leads V4, V5, V6. ST segment depression is there, and minimal elevations also you can see in the lead AVR. So suppose there was no elevations of the AVR and no ST segment depressions in the V4 to V6, you should have labeled them as a normal ECG. But since all these changes are there, you cannot neglect it because there is some subendocardial ischemia. Because how it is evident? Because you can see there is ST segment depression, so subendocardial ischemia is definitely there. So this type of ECG is seen in patients with acute inferior wall MI or inferior wall MI where patient also have a significant concomitant other vessels also. Suppose right coronary artery is occluded, along with that, if other vessels like left anterior descending artery or left circumflex artery, if they have significant stenosis of 90 to 95%, what will happen is because of the significant changes, the vector usually shift. So as we know, anther triangle, this is lead 1, AVF. So lead 2 and lead 3. Suppose there was only inferior wall. This is AVR. So suppose there was only inferior wall MI, there should be elevation in the lead 3 AVF and 2. But all this depends upon the vectors. So suppose ischemia is more here in this direction, more will be the ischemia found here. Suppose a patient have a ischemia of the inferior wall along with that other wall also, the vector sometimes shift otherwise also, and that's why you can see a classical elevation only in the lead 3 and this gets cancelled by the other vectors. So there will be elevation only in the lead 3 and remaining ST segment depression changes in the other leads. This is what is called as Aslanger phenomena. This is very rare, but this has to be kept in mind because this patient is often treated as asymptomatic and sent home. So always be careful because this patient can also land up into sudden ischemia, mortality with arrhythmia. So this is a classical ECG of Aslanger, which is described in 2020, ST segment elevation in lead 3, but not in any other inferior lead. You can see ST segment depression in any of the V4 to V6, but not in the V2. And some ST segment elevation you can see in the lead AVR or lead V1. So identify this. So again, this is a case of uh, called patient is called as you can see here. This is hyperacute T waves. But important thing to differentiate that, as I told in hyperkalemia, how are the ST elevations? So here you can see there is upsloping ST depressions. So ST segment elevation is not there, but ST segment depression is there. However, in hyperkalemia, because often we confuse with hyperkalemia. So hyperkalemia, you can see here, there is some ST segment elevation, then the P wave has peaked. So this is a J point here. So some ST elevation after that T waves has peaked. So this is hyperkalemia. But if there is only ST segment depression and there is peaked T wave, then it is called as the D winter T waves. So it is called as D winter T waves, which is also an indicator of it is called as Stemi equivalent. These patients are suffering from occlusion and you have to immediately reperfuse. So often it is missed and do not take it very seriously, but this patient can suddenly present with STEMI if you do not reperfuse immediately. So definitely patient should be taken for a coronary angiogram. So it occurs around 2% of acute LAD occlusions. Key diagnostic features include ST segment depressions and peak T waves. So coming to the last ECG, you can see here this patient also you can see there is a coving type of ST elevation. Also, there is a prominent or notch at the J point. So this often very much looks like benign early repolarization, but consider patient has to be considered what is called as history wise also. This patient, this similar ECG can be seen in what is called as hypothermia. So this is nothing but a J wave. So this pattern is nothing but it is called as a J wave, which is seen in hypothermia, but looks very similar to the benign early repolarization. Thank you.